Hello and welcome back to Micro 2, where we're going to cover syphilis in Unit 4. So syphilis is caused by the spirochete known as Treponema pallidum. Spirochetes are difficult to grow on traditional micromedia. A spirochete can actually penetrate the skin like Leptospira. Often diagnosed immunochemically in the serology laboratory. Some people are immune and other people progress to latent stages. And the antibodies that are specific to Treponema pallidum are anti-T pallidum, or we can look for biologically nonspecific reagent in nonspecific tests like the RPR. The RPR is also known as the rapid plasma reagent test. Nonspecific reagent can be elevated in hepatitis, mono, and other diseases. So if we're looking for specifically Treponema pallidum, we want to look for antibodies that are anti-T pallidum. If we are looking for biological nonspecific reagent, we are looking for a positive RPR test, but that can be elevated in other diseases besides syphilis. Specific antibodies are detected in what's known as the TPPA test, which is the Treponema pallidum particle agglutination test. Nonspecific reagent can be elevated in a sign of T pallidum infection, but again, it's not specific for syphilis. Syphilis is considered a primary sexually transmitted disease, and it is exacerbated by some fundamental social issues like poverty, lack of health care, and lack of education. There are approximately 12 million people infected every year in the world. It is sexually transmitted by sexual intercourse. You can have oral lesions and kissing, and that can spread syphilis as well. Refrigerated blood products for up to 72 hours of collection. Sharing a bed with an infected person. Usually this is when children are sharing a bed with an adult guardian. And finally, Treponema pallidum can cross the placenta. Sometimes having Treponema pallidum or having syphilis, a person can be asymptomatic. But there are 4 stages in the disease, and they are called the primary, secondary, latent, and tertiary stages. In the primary stage of syphilis, this usually lasts 1 to 5 weeks. Here there's a chancre present, and usually it's contagious about 10 to 60 days after contact with an infected person. The organism here will penetrate the skin, and you can see spirochetes in the sores and the blood. We usually use what's known as a dark field exam to see the spirochetes in the chancre. In secondary syphilis, this develops about 6 to 8 weeks after contact with an infected person. The chancre at this point disappears and lesions will be apparent in the eyes, joints, and central nervous system. There is a rash that appears on the palms of the hands and of the feet. This can be diagnosed with serum antibodies such as RPR or TPPA testing. In latent syphilis, this develops about 1 to 2 years later, and a person may be asymptomatic during this time. Generally, during latent syphilis, the patient is no longer contagious and is not usually diagnosed at this time either. We can usually test for serum antibodies for latent syphilis. In tertiary syphilis, this is also referred to as neurosyphilis. This occurs 3 to 30 years later. In fact, 50% of patients go into this neurosyphilis stage. During this stage, there are serious complications that can occur, including complications to the central nervous system, heart disease, and blindness. Now, sometimes in tertiary syphilis, a patient can be asymptomatic, but that's usually unusual. Antibodies in the serum are usually cerebral spinal fluid antibodies. In this stage of syphilis, our lymphocytes are increased, especially in the cerebral spinal fluid, and also your cerebral spinal fluid protein is going to be greatly increased. Here we can look for specific and non-specific antibodies from the disease syphilis. A specific antibody that is looked for to diagnose syphilis would be anti-Treponema pallidum. A non-specific antibody can be non-specific reagent. Anti-Treponema pallidum is seen in the Treponema pallidum particle agglutination test or in the fluorescent Treponema pallidum antibody test. Nonspecific reagent can be seen in VDRL, which stands for the Venereal Disease Research Laboratory Test. That's a test on cerebral spinal fluid, or the RPR test, the Rapid Plasma Reagent Test. This is a nonspecific reagent test that can actually be elevated in other diseases such as hepatitis and mononucleosis, but it's also going to be elevated in people that have syphilis. There's several ways that treponema pallidum or syphilis can be diagnosed. Dark field microscopy is usually one of the first things they're going to do, and that happens in primary syphilis. You might actually get false negatives if they're being treated. Here we look at the Schenker scrapings, and we're going to look for bright spirochetes on a dark background. We can do direct and indirect fluorescent antibody tests. We can perform what's known as a direct fluorescent antibody test. We can do rapid plasma reagent, which is the RPR test on serum. We can do the VDRL test, which is a diagnostic test for neurosyphilis in the spinal fluid. We can also use gelatin particles to do the treponema pallidum particle agglutination test. We can do DNA probing, which is PCR confirmed by Southern blot. Or we can also do EIA or ELISA looking for treponema pallidum antibody. This actually could be near 100% sensitive in all phases of syphilis. If you haven't heard of Southern blot before, I just want to explain Southern blot. Southern blot is when you have DNA fragment detection by probe hybridization. Dark field microscopy is used to diagnose primary syphilis. It's not very sensitive and requires about 100,000 organisms per mil in order to see the spirochetes on a dark background. It does require expertise in dark field microscopy and very specialized techs. We use dark field microscopy to diagnose primary syphilis when the patient is symptomatic. Like I said, spirochetes are going to appear bright on a dark background microscopically. There are DFA and IFA tests that we can use for the detection of treponema pallidum. A direct diagnostic method for fluorescent labeling antibody conjugate to T. pallidum organism is the direct method, and an indirect method is when you have a diagnostic method using T. pallidum and a secondary labeled anti-immunoglobulin antibody. That would be an indirect method. The RPR test, or the Rapid Plasma Reagent Test, is a screening test for syphilis. It is most widely used as a non-treponemal serological procedure, but it can be elevated in other diseases like mononucleosis, malaria, hepatitis, and lupus. This is called a biological false positive. Here in the RPR, we are screening for non-specific reagent in the patient sample. An indirect or passive agglutination test using antigen-coated charcoal particles. The antigen is a mixture of beef heart and charcoal, and that is known as cardiolipin lecithin cholesterol. So in this test, the antigen is cardiolipin lecithin cholesterol, and the antibody is nonspecific reagent. Together, we look for passive agglutination where the charcoal particle and the patient's serum combine. Here's an example of a control card and a test card for RPR. Here we can see the antigen, which is the charcoal, is attached to the antigen, and patient serum are mixed together. We rotate the mixture for 100 RPMs for 8 minutes, and we look for agglutinins. We report out the results as either reactive, weak reactive, or non-reactive. And you can see on the control card on the upper left that we have large agglutinins in the positive or reactive well. We have small agglutinins in the minimal or moderate or weak reactive well, and we have no agglutinins in the non-reactive well. The VDRL is an acronym that stands for Venereal Disease Research Laboratory. This is a cerebral spinal fluid screening test or non-treponemal test for possible syphilis. Samples must be heated to 56 degrees for 30 minutes in order to inactivate complement before doing this test. Samples can be serum, but generally for VDRL we are using cerebral spinal fluid. The antigen is cardiolipol dissolved in ethanol and buffered saline. The antibody that we're looking for in the patient is the same as for the RPR. We're just looking for reagent. Latex particles are coated with the antigen and we look for flocculation. This is an indirect or passive agglutination methodology. You can actually get false negatives on this if the patient is being treated. In a biological false positive, you can actually get a positive on the RPR or a VDRL even if it isn't Treponema pallidum causing the reaction. This is a reaction with serum that is from the presence of an antibody not specific to the antigen used in the test. Biological means that it's caused from another living thing or disease association. Some things that can cause biological false positives would be autoimmune diseases like systemic lupus erythematosus or rheumatoid arthritis. Other things that can cause biological false positives would be rheumatic fever, viral hepatitis and mononucleosis. Acute bacterial or protozoan infections like leprosy or malaria can also cause biological false positives. Biological false positives can be seen affecting reactions in the RPR and the VDRL tests, but do not affect confirmatory tests like Treponema pallidum particle agglutination. It only affects the screening tests like RPR and VDRL. So if you get a positive on the RPR or the VDRL, it doesn't necessarily mean our patient has syphilis. It's just a screening test for syphilis. If you have a positive RPR or a positive VDRL test for your patient, then you must confirm it with what's known as the Treponema pallidum particle agglutination test, also known as the TPPA. This, like I said, is a confirmatory test where we're looking at semi-quantitative particle agglutination. The antigen used in this test is gelatin particles that are sensitized with T. pallidum. The antibody we are looking for in the patient's serum is anti-Treponema pallidum. This is considered an indirect or passive agglutination procedure, and I'm going to show you what this looks like in the next slide. So here in the third column, we can see little buttons of sensitized particles. And because we see buttons, those are all considered negative. Anytime you see a button, that is considered a negative well. If you look at the first row and the fourth column, you can see there's a flat mat. That is considered a positive. So if you look at that patient in the very first row, we can say the first well is non-reactive. The third row is non-reactive with the button, but then the fourth, fifth, sixth, and seventh, and eighth row are all reactive. So the titer on this person would be the end of that eighth row. In DNA probes, we're not looking for an antibody in the patient sample. Instead, we're harvesting molecular material and then match it to treponemal DNA. It's a very expensive form of testing. In ELISA, we are looking for IgM or IgG antibodies to Treponema pallidum. Generally, the ELISA method looks for IgG antibodies that have crossed the placenta and have infected the newborn, leading to congenital syphilis. And here's the procedure for the RPR. It's pretty easy. We take 50 microliters of our patient sample and put it on a test card. Then we add 1 calibrated drop of antigen, which is cardiolipin, lecithin, cholesterol on charcoal particles, to the test circle, and we mix them together. We rotate it on a mechanical rotator for 100 RPMs, plus or minus 2 RPMs. And at the end of 8 minutes, we look for agglutinins. If there are agglutinins in the circle, we report that out as reactive. And if they are small agglutinins, we report them out as weak reactive. And if there are no agglutinins, we report that out as non-reactive. You can actually do a quantitative procedure as well, where you do a 2-fold serial dilution, and then the rest of the procedure is the exact same way, but we actually record out the titer of the RPR. The TPPA test is probably one of the most complicated tests that we will be touching on in serology. Hopefully we'll get a chance to do this in the serology lab. But in the TPPA, we're essentially making serial dilutions of our patient's serum and testing that patient's serum against either sensitized gelatin particles or non-sensitized particles. If our patient's serum reacts with the sensitized particles, you're going to see a flat mat in the dilution well. Okay, a flat mat or anything up into a big donut indicates a positive well. A nice tight button equals a negative well. If you have a non-reactive RPR or TPPA, we can say the patient doesn't have the disease. Or we could say the infection is very early in the stage and they haven't produced any antibodies to the disease yet. Or our patient could be temporarily non-reactive after their treatment has occurred. Or we could have an inferior technique used by the tech. Or even alcohol can make a person have a false negative. Weakly reactive tests, we could say there was inferior technique used by the tech, or the disease could be in the very early stages, or there could be a biologic false positive giving us the weak reactive results. In a reactive test, either we can assume our patient has syphilis, we can assume it's a biological false positive, or finally we could say that it's inferior technique by the tech. Okay, but we always report out the test for syphilis as either non-reactive, weakly reactive, or reactive, and then we have to interpret what that means.